everyone, and welcome to our series, Simplify and Comply. My name is Kim Wilson, and I'm a senior consultant for the Greeley Company, specializing in regulatory compliance and informatics. During these series, we touch on topics that we typically will see cited during a survey, and walk you through some steps to hopefully help you simplify these processes and be in compliance for your next survey. You can look for other topics in our Simplify and Comply series, but today's topic is all about care planning. So our objectives for the day will focus on what's really required for care plans. It's really important for you to understand what the regulations say, but more so, it's important to understand the impact care plans can have during an adverse event in your organization. We'll talk about what we typically see during survey from a care plan perspective, discuss some potential solutions that can easily be implemented, and possible long-term recommendations as well. Care plans have consistently been in the top 10 citations for both CMS and Joint Commission for several years now. In our experience, care plan failures are fairly easy to identify because most staff feel that care plans are burdensome, something they have to do, provide little to no value add, and are truly just an afterthought. As a result, there's typically not a lot of thought or effort that goes into care planning. I get it. I felt this way for many, many years until I joined the compliance world and truly realized why care plans mattered so much, not from just a regulatory standpoint, but from a patient standpoint as well. We have to remember that care plans aren't ever going to bring a surveyor into a hospital, but adverse events will. And almost every time an adverse event happens in our organization, care planning will generally be one of the biggest issues identified during that investigation. So care planning shouldn't just be something we do at the end of our shift before going home, or something we do because we know we're going to get a love note from our boss if we don't do it. As leaders and healthcare providers, we really need to look at care plans as an essential piece of the puzzle for the well-being of our patients and for our organization. It truly has to be a team effort. From a long-term solution standpoint, Greeley believes care plans should be part of the natural nursing process, where we assess, plan, treat, and evaluate, all in one part of the EMR. But that's part of a larger solution we can discuss later. For now, let's take a look at what's really required from a regulatory perspective. First and foremost, care plans must be updated to reflect ongoing needs of the patient based on their assessments and reassessments. So we have to make sure that when we're updating our care plans, we have to take into consideration the ongoing needs. So every shift we do assessments and reassessments of the patients. And so the care plans really need to make sure that we incorporate into those care plans part of that assessment and that reassessment. So what's really going on with that patient? Are they getting better? Are they getting worse? Are there new issues identified? You should be able to look at the care plan at any time and tell what's happening with that patient. Interventions have to be tailored to meet the patient's goals. So this is fairly new. You have to make sure that the interventions that you develop are tailored for that patient-specific goals. The issue we typically see here is there's interventions that are rote, that are just built into the EMR, that we use over and over and over, that sometimes aren't even applicable to what's going on with the patient. So we have to make sure that we're customizing our care plans by making sure that interventions and the goals meet the needs of the patient. We have to make sure that we involve the patient in the care plan process, if and when possible. I know that's not always possible, but there's family members or support team members of that family that you can get with to help incorporate some of the needs of the patients or the needs of the family members into that care plan process. CMS actually calls out specific times when you must include the patient in their care planning process. And this would include discharge planning or pain management. So those are some times when CMS specifically says you have to involve the patient in their care plan process. Also, you have to show an interdisciplinary collaborative approach to care. So Joint Commission really goes much deeper into this than CMS does. However, CMS does touch on this throughout the regulations. So we discussed earlier how adverse events can bring a survey team into a hospital. This is one where you really need to pay attention to the different disciplines in your organization and how they're working collaboratively to discuss the needs of the patient. So I see this cited, especially during adverse events, when surveyors come in and they see that nursing is on a different page than the providers versus the dietitians versus physical therapy. Care is just not being coordinated in a collaborative manner, and that's when you'll get cited for this standard. One of the biggest issues that we see in a hospital is not following your own policies, and there is a multitude of reasons for that. Policies can be overinterpreted, and one of the worst things that can happen is when you get cited not for a regulatory requirement but for your own policy, and this happens a lot, especially with overinflated, overly burdensome written policies that are extremely long, that staff just don't take the time to read. So we see that happen a lot with care plans. So what our typical findings are when we go into any organization and we review care plans as part of a mock survey, normally we're going to see that care plans are just not customized. So you're going to see patients who have the same types of care plans, the same types of interventions throughout the different organizations. So if you look, for example, in an ICU, you may see that every single ICU patient has the same 5 care plans. Or if you go to an L&D unit, all L&D patients have the exact same 3 care plans. They're just not customized to what's going on with that patient. Now, those patients may have similar issues, but you really, to meet the intent of the standards, you have to make sure that you're customizing them to those patient-specific needs. Another thing is we see is care plans not being updated. And this is a couple of different reasons here. So you may have a care plan policy that says how frequently care plans have to be updated, so we can see issues with that. You can see where care plans are initiated on admission, and then days later, you can't see where there's been any updates to that care plan. So the patient may have changed level of cares, they may have transferred from an ICU out to a telemetry floor or a med-surg floor, and they still have a ventilator bundle as a care plan. So clearly, care plans aren't being updated when we see things like this. We also see that care plans aren't updated based on the ongoing needs of the patient, which would be based on their assessments and reassessments. So one really good indicator for us is to be able to look at an assessment, a daily assessment completed by a nurse, and look at the problems that were identified during that assessment, and then look at the care plans to see, can I see where those needs of the patient are reflected in the care plans? And if not, then you're probably not meeting that regulatory requirement. There really needs to be something in the care plan that is reflective of the problems that were identified during our assessments and reassessments. And that includes for physicians, dietary staff, any discipline that's coming in to look at the patient. There really should be some kind of an update to the care plan based on those new findings. Lack of care plan availability. So I work with a lot of EMR vendors, and they're pretty much all the same as far as functionality. You've got usually a pick list of care plans to choose from, and sometimes that list is very robust, and sometimes that list can be very slim. I've recently gone into an organization that literally had less than 15 care plans for the whole entire acute care healthcare system. There's no way that 15 care plans can be applicable to all the different needs for the patient populations that were coming into that organization. So in that circumstance, there was many times nurses said to me, I just don't have the care plans that I need. And there's no way to build care plans on an ad hoc basis. So staff were left choosing from the 15 care plans that they had in their pick list. So there really needs to be the appropriate amount of care plans, the appropriate types of care plans for the patient population that you're serving. Policy knowledge. This one's pretty big, and this goes into a very much larger policy conversation, but typically what we see is hospitals will develop policies, and for whatever reason, there's not a lot of staff knowledge of what's inside those policies. Staff pick and choose kind of what they want to know about the policies, and they don't know the minute details of them, which is why we really encourage policies to be slim, trim, to the point, and intended for the people who are trying to implement those policies, not for a surveyor. So you really have to make sure that staff have knowledge of the policy, because this particular finding gets people cited more often than most of the other issues that we find. And it's simply because staff don't know what's in the policy and what the policy requirements are. The last thing we see is the stringent requirements. So a lot of times, surveyors will come into a hospital and cite you for something, for care plans or for you not updating care plans the way they wanted to see them. So the first thing that we do is have knee-jerk reactions to add additional criteria to our policy, when really it could have just been an educational issue or something along those lines. We never try to fix a problem by adding more criteria or trying to burden staff, or more importantly, trying to force staff into compliance through policy, because that's truly a myth that's never going to come to fruition. You cannot force compliance through documentation, and you cannot force compliance through policy. It's just never going to happen. So if you want compliance, there's other ways to get it than forcing it in through policy. And you're actually hurting yourself by adding more stringent requirements than what the regulations say, because that's when we see people get cited. So make sure that your policies don't have a lot of additional requirements that truly aren't required by any of the regs. So I want to talk to you about some simple solutions. Now, obviously, there's some long-term, more in-depth, robust solutions that we offer, but there are some simple things that you can do to fix a lot of the issues that you may be seeing. Now, I say simple, kind of tongue-in-cheek, because I know that simplicity takes time and effort, but your return can be quite substantial if you make sure that you have these next steps in place. So first and foremost, truly simplify your policy. Your care plan policy should not be likely more than 1 page, maybe 2 if you have it incorporated into an assessment reassessment policy. But truly, this is a small, simple policy that staff should be able to pick up, quickly read, see what they're supposed to do, and understand, and not be 15 pages long. So to write this policy, you really need to understand what the regs are, and we've gone over those. So you know what's required, and you probably now know what's not required. So there's not a lot of time frames associated with care planning. Those are left up to the institution to decide. So you have to allow for some flexibility in your policy to make sure your staff truly have time to get the care plans completed. You also need to make sure that your requirements are consistent among units. One of the worst things I see happen is I go into a hospital and there'll be a care plan policy for ICU with very stringent and tight parameters, such as care plans must be initiated within 30 minutes of arrival to the unit, or care plans must be completed within an hour of arrival to the units, or upon arrival to the units. Whereas a med-surg or telefloor says that they have 8 hours to complete those, and other units have 24 hours to complete their care plans. So it's never really a good idea to make different requirements for different units, because care planning should be standardized across all units. There's no reason to have a different standard of care when it comes to care planning for different levels of care within the organization. Care plans are care plans, no matter what. It doesn't matter whether you're in an ICU, an L&D, postpartum, tele, med-surg. They should be consistent across your organization. When you allow for flexibility in your policy, you really are helping your staff nurses to be able to be flexible in how they develop their care plans and the time frames associated with that. So it really does offer a model policy for care planning for our membership clients that has some caveat statements that really will help you to get around a lot of the citations that you're probably receiving today. So one of the things that we like to do is to say that the record in itself, your EMR in itself, is a care planning tool. So physician progress notes, your dietitian's notes, your physical therapist notes, your nursing notes, they all contribute to the overall care plan of the patient. And this does a lot of different things. This allows for your subject matter experts, like your dietitian, to be able to come in and see the patient and come up with a very detailed note, assessment with plans and goals for that patient, and then not have to burden the nursing staff to also duplicate maybe a care plan on nutritional needs, because who better in the hospital than your dietitian, your nutritionist, to know the plan and how to make that plan for that patient. So the thing with this is you really have to just make sure that everybody's on the same board. So if you're going to implement this kind of policy, which we highly recommend, it's best to make sure that all people involved, all your different disciplines, especially nursing, who will be questioned the most on this during survey, have awareness and can get to all of the case manager notes and the physical therapy notes and your dietitian notes. So when a surveyor asks the nurse, why don't you have a nutritional care plan on a patient who has a PEG tube? She can say, or he can say, we do have a care plan and let me show it to you, and point them in the direction of the interdisciplinary care plan that's completed by the subject matter expert. And that is absolutely legitimate. You can absolutely do this. We do this all the time. We pass surveys with CMS, Joint Commission, DNV. There's absolutely no rules that say you can't do this. So there's a couple of things you can do in policy like that to truly help you during survey. Again, it's about coordination of care, collaboration, and communication, and making sure everybody's on the same page. Next, we highly recommend that you inventory your care plans. So like I said earlier, you have to make sure that your staff have what they need to get their job done. That is Leadership 101, ensuring that your staff have the tools to complete their job. So one of their tools is a care plan. So you have to make sure that your staff have the common diagnoses, right? I mean, when a patient comes into a hospital, we do ICD-9, we do ICD-10 coding on those patients. We know what the common diagnoses are in our hospital. You likely have someone within your organization who could easily write you guys a report to show you what those common admission and discharge diagnoses are, and then go look to see, do I have care plans that are applicable to that diagnosis? And if not, you probably need to get one. Also, the biggest thing for me is to talk to your staff. When I go into a hospital and I'm reviewing care plans as part of the nursing standard, I always ask the nurses, do you have what you need to develop care plans? Do you have the appropriate care plans? And typically they're going to tell me no. They're going to say, I need a care plan for seizures because we always admit seizure patients up here, or they're always in seizure precautions, and I don't have any kind of care plan that would be relevant for that type of patient, or a diabetic care plan. I have nothing about the endocrine system that I could add to that patient. So they're trying to have care plans that are really not relevant added to the patient and just hope that it'll pass during survey. So go out there and talk to your staff. You'll probably be really enlightened about what they have to say and probably come up with some pretty quick solutions on how you can fix this. Another thing is managing expectations. You've really got to look at how you train people, what you expect of people, and then think about what the reality of the situation is. So is there consistency among units and staff? Again, one of the worst things I see is when we go in and we find an inconsistent practice among units. Now, a lot of this will have to do with your policy, but sometimes you'll have unit managers who make decisions on their units that this is just how we're going to do it on our floor. And I really try to talk people out of this kind of mindset, because you really do need to have consistent practice. From a nursing perspective, it's really hard to get floated around in a hospital and have different practices that aren't dictated by policy, but dictated by a unit manager. And I see this a lot when I go into hospitals. Some unit manager, maybe in an ICU or an oncology floor or a specialty unit, will determine that on their unit, they're going to do something different than they do in the rest of the hospital. And that's just really not good practice. What does it mean to even update a care plan? This is a big one for me, because when I go in and I talk to nursing staff during survey and I ask, show me how you update a care plan, or show me where you did update a care plan. A lot of times I'll see where they'll show me a screen that they clicked a button that said patient progressing towards goals, patient progressing towards goals. And they click this button 15 times for 15 different interventions or 15 goals. But when you talk to the patient, or you talk to the nurses about the patient, you find out quickly that those interventions and those goals aren't even relevant to the patient anymore. It's just really a rote activity that they go in and click these buttons. So I really want people to think about care plans in a different way and manage our expectations about what does it really mean to update a care plan. It really needs to be a process, not a piece of paper. not a button. It has to be a process. We have to look at the way that we update care plans, and it truly should be based on the ongoing assessed needs of the patient, and not just a practice where we go in and click a button and say the patient's progressing or not progressing. So for long-term solutions, again, I said earlier that Greeley does offer some long-term solutions that are much more robust and take a little bit more time and effort, but we've managed to do this in a number of different hospitals and have had really good outcomes. So if this is something that you're interested in, we'd be happy to talk to you about some of our long-term solutions, such as our nursing documentation simplification plans, our EMR redesigns. We come in and we can look at your care planning process, your assessment reassessments, your admission assessments. We can look at physician documentation, restraints. We've managed to reduce documentation on restraints in many hospitals and still be compliant. Falls and hourly rounding are just some of the topics that we touch on. So if this is something that you're interested in, we'd be happy to talk to you. But again, I would really encourage you to look at the simple solutions that we've offered up here today. Try to take those back and implement those in your organization and see if you can truly make a difference, because even the simplest of things can truly make a substantial impact. If you have any questions, comments, or feedback, please feel free to reach out to us. You can give us a call at the number on your screen. You can also email info@greeley.com, and you're always welcome to visit our website, www.greeley.com. I hope you've enjoyed our session today on care planning, and I hope that you're able to go back to your organization and implement some of those simple changes that we've offered for you. Thanks very much.